that can prevent this. We have treatments that can stop an attack. So it's really up to us as a community, but also as societies, to help increase awareness, to reach every patient, no patient left behind, to minimize the duration that it takes to get the right diagnosis and thereby also correct treatment. HAE is very dangerous, but it is also impaired during and in between attacks. Once patients start to have attacks, they are afraid of having the next attack. Understandably so. This is super frightening and affects their mood and well-being. And this is why we see in many patients, especially untreated and undiagnosed, depression and anxiety. Why? Because they are afraid that this will happen. Because they know someone in their family, grandpa or grandma, mama or papa, who had severe attacks or died from the attack. Almost all of my patients remember family stories about the death of one of the family members. And that is very, very frightening to patients, in addition to the other impairment that comes with hereditary angioedema. So we as treating physicians must do everything to help patients get the right diagnosis early and the right treatment to minimize the impact that this disease has on our patients. Even with low numbers of attacks, and who is to say what is low? What's a low number of attacks? One per week, one per month, one per year? It's relative to patients and what these attacks do to our patients. So don't look at the number of attacks so much to make treatment decisions. Look at the patient and what the disease does to the patient, including the outlook on life, the well-being, the quality of life. Now, we have a fantastic guideline, which is in the process of getting even better. Many of you have already registered to contribute, come to the expert panel. And in this guideline, for the first time, we say that the aim, the goals of treatment in hereditary angioedema, black and white, are total control. I love that. Total control. Total is 100%, not 99. 100%. Total control. We want patients to be in control of their disease. We want patients to be able to do anything they want to do. Climb Kilimanjaro, play in the desert, go swimming, have a party, whatever they want to do, without running the risk of or fearing an attack. This is what we want. This is what total control means. This is what it means to normalize patients' life. That's the aim of the treatment, and that's the aim of our management. And in order to do that, we need to measure. And we spent some time yesterday, for those of you who were in the workshop, you will remember, we want no attacks, complete control, and a normal life. This is where the goal is, and this is where we need to bring patients with the treatment we have. And the treatment we have are, of course, to help them when an attack occurs early on, as early as possible. Every patient must have treatment that saves their lives or stops any attack that they have. But more importantly, if we say that total control is the goal, then currently the only way to get to that goal is to not have patients have attacks. Once they have an attack, they lost control. So prophylaxis or prevention is the only way to achieve the goal. Right now, this is what we want, and right now we have the tools and means to do that. And actually, you need more than good medication. You also need guidance on how to use this medication to its best. And this is done by measuring the disease activity, control, and impact. Remember, total control. So if we want to know that patients have total control, we must measure it. Otherwise, we don't know. Have we reached total control? And we do that with the tools available. And yesterday, it was actually quite nice. We did these tests together. We went through them. We answered the question. We calculated the score. And it's so easy. So easy that every patient can learn that and can do that. And what we want to do is, by collecting the points here, 16 is the maximum, show patients where they stand. Have they reached 16 points? Or is there room for improvement? 10 is already okay. 10 is well controlled, still not there. Total is total. 16 is total, but we know we're on the right track once we bring them from less to 10 to 10 or more. Okay, now just measuring doesn't give our patients control, but it allows them to see where they stand. Now we need to go the second step, not only provide patients with the tools, which are available in more than 90 languages, including several Arabic versions, but also then act by providing treatment. And this is a shared treatment decision where we need to guide patients as best as we can, but also make it clear what our expectations and goals are. So when we say, I want you to lead a normal life, many of my patients go, what? How will this be possible? No, I've had this disease since my parents had it, my brother has it, and here I'm hearing for the first time that your goal is to give me total control. Yeah, they need to hear it from us, no? That this is what we want for them, and that we will not stop short before we have achieved this. And why are we so confident to say that my goal for you is complete control? We're confident because today we have 3 drugs, 3 treatments that are first-line prevention treatment. In other words, not only can we provide good treatment to stop an attack, no, we can provide treatment that allows our patients to stay healthy. And it is these 3 treatments that we talk about when we talk about achieving the treatment goal. What are these first-line treatment options? They are tried and true, had it for a long time, plasma-derived C1 inhibitor. The one thing that patients are missing, the one thing that's not working in patients with hereditary angioedema, that we replace by giving it to them, that they replace by giving it to themselves. Now we have 2 kallikrein inhibitors, and I won't go into detail, just show you where they act. We have an oral one, we have an injectable one. All of these are first-line treatments. In other words, if one or more of these are available, those are the ones that we should talk about, and those are the ones that we should bring to patients. The days of doing nothing, the days of working with androgens, the days of working with tranexamic acid are over. This is the past. The now and the future are safe and very effective treatment options, including the 3 that you see right here. Okay, let's look at this a little bit because, yeah, it sounds simple. Just pick A, B, or C, 1, 2, or 3. But there are actually some things to bring on board. Every patient is different. Not everything works in everyone, and not everyone wants everything. This is shared decision-making where I sit with my patient and I mirror. I look at the patient. When do the eyebrows go up and when not? I talk about, this is one that you inject. This is one that is a pill. This is one, this is one, this is... And in that conversation, I get to see from my patient what is exciting to her or what is not so exciting to him. And this is shared decision-making, moving forward together. So, what other comorbidities are there? How much are patients affected? But also, how do they see these treatment options? What is important to them? Do they not mind to inject themselves, or do they hate injections? Would they rather have it once a month or take something every day? I don't know that. I need to talk to my patients about this, and I also need to be sure that they will be using this treatment, that they are able to use this treatment, that it fits their life and their lifestyle. So there are many things to consider, many things to talk about, but my major point is, I'm not deciding for my patient, and the patient also is not deciding for herself. We're deciding together, talking about what treatment fits best for which patient and what time. Making a treatment decision once does not mean that we cannot change this treatment decision. We may have to adapt, we may have to change, we may have to combine, we may have to adapt the treatment. And this is key in HAE just as much as in any other disease, but we didn't have much of a choice or alternatives in the past. Now we do, so let's make use of them. You all know how this works. Factor 12 gets activated, runs through this cascade. It's like an avalanche, starting with a little snowball. Well, at the end, you have lots of bradykinin making the making the angioedema. We can stop this avalanche at several points. And actually C1 inhibitor, the best and best established treatment option, both on demand as well as prophylaxis, interferes with this avalanche at several points. So we have multiple targets in that cascade that get inhibited by the C1 inhibitor. The kallikrein, on the other hand, is a bottleneck. So if you stop that, if you think this is gone, whatever happens up here doesn't matter, because this does not happen. So it's a very effective way to stop the cascade right here. And it does happen with two kallikrein inhibitors, lanadelumab and berotralstat. So let me share a little bit of insights, and I will start with the tried and true because it still has value in today's prophylactic and on-demand treatment landscape. This is plasma-derived C1 inhibitor, the one that people are missing who have this disease, the one that we give back. And from several trials, and this is a good one with a sizable number of patients, we clearly know that when it is given as prevention, it brings down the number of attacks tremendously. And because it is what people are missing, and because it normalizes the situation, it also normalizes quality of life. These are all different aspects of quality of life that get benefit from treatment with plasma-derived C1 inhibitor. Maybe more importantly, there are some situations where plasma-derived C1 inhibitor is the only recommended prophylactic treatment option, namely pregnancy. It is an endogenous protein, so there's no harm at all at giving it to patients who want to become pregnant, who are breastfeeding. And you see from all of the evidence that is out there that it's perfectly safe to do so. And why wouldn't it be? It's the protein that is missing, a protein that all of us have, a protein that no antibodies are being made of. No harm comes from this. And it does work in pregnancy just as much as it works outside of pregnancy. So clearly for patients, HAE patients, type 1 and type 2, the ones with C1 inhibitor deficiency or dysfunctional C1, this is the treatment of choice when patients want to become pregnant or are pregnant. And in this setting, it is very well established that it's a very safe treatment. And that also goes outside of pregnancy. It is a very, very, very safe treatment with more than 50 years of experience and use. So that speaks to it, and that is something that should be considered when we talk about the treatment options that we have. Coming to the kallikrein inhibitors, more modern treatment, two flavors, I want to say. So a pill that is taken daily called berotralstat, a small molecule, now approved for hereditary angioedema in patients 12 years or older, and lanadelumab. And you heard, maybe most of you, Thomas Buttgereit from our team talk about lanadelumab with berotralstat a little bit. Also now long-standing experience. We've used it for many years. It is indicated in the same patient population, 12 years or older. And I would just complement what Thomas talked about by giving you some numbers of what these newer drugs can do. You reduce the number of attacks to almost nothing. And once you reach plateau and only count what happens after day 70, when the drug is still increasing its reach, it's nothing. And by nothing I mean, well, what are the rates of responders? Total control, no attacks, normal quality of life. Well, this goes towards 80%. 8 out of 10 patients who use this treatment reach the treatment goal with the standard treatment and protocol. So this is very, very good. This is what we want. We want to be confident to say, look, if you do this, you have a good chance, very good chance of reaching the treatment goal. And all of this with a treatment that's safe. And why is that important? Well, it's important And it's more important because this is a lifelong treatment, at least potentially. It's a lifelong disease, and we do not have evidence that HAE gets better in age or that it changes. It's a tremendously fluctuating disease, unpredictable. So many patients who experience the benefits of long-term prophylaxis, they want this. And we need to be confident that we can provide it without putting our patients at risk. In the meantime, you've seen what the side effects are. They are transient, they are rare, and mostly limited to the injection. I'm going to give away a little tip and trick that I learned from a patient. It was first a patient who used icatibant. Who of you have used icatibant in your patient? Any? Okay, quite a bit of experience. Super. Okay, so icatibant is the on-demand treatment, and our young doctors, when they used it as on-demand treatment, well, they took it out of the fridge, half of the syringe into the room, and the other one as fast as possible into the patient. No, boom. It hurts. It hurts. I tried it myself. It really hurts. But it doesn't hurt when? It doesn't hurt when you warm it a little bit. That's good. It doesn't hurt when you don't do that, because then you put a little bit of the medicine. Well, first of all, it's not good. I want all of this in the patient, not in the room. And you don't put that little drop of medicine on the tip, which then, when you go into the skin, will go through the upper dermis, hit the mast cells, hit the sensory nerves, give them a lot of action, and that results in erythema, itch, pain, burning, and sometimes also whealing. Now, this is similar with lanadelumab, not quite to the same extent, but when I applied lanadelumab, well, I did it like I apply a sub-Q injection, like omalizumab, no? But patients do it differently. First of all, they don't do that, never. They want all of this themselves and not on the ceiling, and they go nice and slow, and deep. Never like this, but deep. Oh, there's always a little bit that you can fill here, and if you do it nice and deep, then you minimize these injection site reactions that were seen in the clinical trial. I have very few patients who actually say, I don't like the day of injection because I have this injection. So try it with your patient. I've learned it from mine, and I can recommend that you pass this on. Thomas talked about the Berlin Protocol. And what the Berlin Protocol does, and I will review this with you because he went really quick, and I want you to understand that this is really of benefit to implement, comes from our first patients. Lana is given every 14 days, okay? It's a subcutaneous injection given every 14 days. Now, we tell our patients, before you give injection 3, let's talk. And this is even easier for you because now I know that you see your patients to give the injection. So you can ask your patient, have you had any attack? And if the answer is no, you add 3 days. Maybe we'll call them at home and ask. And so we will then extend the interval from the second injection so that the next injection is not given after 14 days, but after 17 days. And the idea behind this, as Thomas was explaining, is to get the most out of the drug. Not necessarily only to save money, yes, that it does that too, but also to minimize the treatment burden, right? What is the treatment goal? Total control and a normal life. Okay, total control we have, albeit shortly. Normal life, not so normal to inject yourself every 14 days with something, but a lot more normal to do it only every 4 weeks or 5 weeks, right? So normalize as best as possible the life of patients. And so you add 3 days until things go wrong, until the interval was too long and patients have a breakthrough attack. Now patients know if they go beyond this point, it's too long. I need to go back. And we do this by 2 intervals. No? We go to here, which was a perfect interval for the patient, no attacks, and continue with this interval until we then, in the future, try another extension of the interval. This is how we optimize, individualize for patients the use of the drug. Patients love it. They love to be in control and working with the drug and helping to find for themselves the perfect way to protect themselves from the attacks. With that, within a short period of time, The Berlin protocol brings 90% of patients to 4 weekly injections. And as Thomas has shown you, now 4 years later, we have about 30% of patients who go beyond the 4 weeks, who go 5 weeks and 6 weeks. At one point we say, okay, piano, because we don't want to increase the risk of you having a breakthrough attack too much. But if someone gets 5 weeks out of it, great. They like to have as little injections as possible with as best of quality of life improvement as possible. And it is amazing to see what it does. On average, patients come from uncontrolled disease and move to, what's total control? 16, 15 points. Many patients reach the 16 points and are completely free of signs and symptoms, have complete control, do anything, climb Kilimanjaro, go to the desert, do whatever they want to do and weren't able to do before. Now they're in control. It doesn't end here. This is a fantastic beginning for patients with hereditary angioedema. But 2 more things need to happen. Now that this treatment is available, we actually need to provide patients with it and bring patients to where they can be provided with these drugs. And that means we need to identify each and every patient who has HAE. And I want to talk with you and the panel about how are we going to do that? What are strategies that work in our countries, in our settings, in our communities to bring patients to us, to explain the disease to them and what this disease means and how we can help them to be protected from the consequences. And not everything works for everyone. We still need better treatment options and are very happy that industry continues to develop better drugs for people with hereditary angioedema. Targeting kallikrein, targeting the bradykinin 2 receptor, orals that could be taken on demand. No, not so much fun to carry your EpiPen around, not so much fun to carry your icatiband around. We're glad we have it, don't get me wrong, but wouldn't it be nice if this were a little pill that's in my wallet that I pop when I start to feel the attack? Oh, would be nice. An oral EpiPen, an oral icatiband. All of this is in development, and this is good. We encourage that. Now, you heard yesterday, gene therapy is underway. We have 4 patients in Berlin on CRISPR-Cas gene therapy for hereditary angioedema. 5 years ago, I would have accused you of science fiction failure. No. This is real. This is happening right now. This is a disease where we tremendously benefit from the insights on the disease, but also the advancements of drug development and new treatment options. So we're very happy about what is going on in HAE, but not so happy with how this is actually translated to the benefit of patients, at least not in some of the regions where it's our job to do this. And we always think about how to better do this. In my country, I'll tell you that some of the biggest challenges are to reach patients who are actually not at A-cares, not at centers of reference and excellence, but maybe at a local doctor with little experience and little expertise in hereditary angioedema, not aware of the newest treatment options, not aware of how to monitor patients. I like to think that we have no more androgen patients in Germany, and certainly within our 300 patients with hereditary angioedema, 0, none, zilch, nothing. We don't prescribe it, we discourage it, we take it away from them. That does not mean that there are no androgen users in Germany. So we all have something to do in our communities, and it may be very specific. It may be different in Oman than it is in the Emirates. It is very different in Germany. It may be different in other parts of the world. I want to discuss with you and learn from you, what can we do to help patients to get the right treatment, to use it to the maximum of their outcome, and how do we bring treatment to all patients who need it. This is my A-care, or our A-care in Berlin. Yesterday I said, these are not people we lost, and that's true. These are people we're looking for. So if you have someone, know someone who wants to help us in Berlin, help with the understanding of hereditary angioedema or related diseases, send them my way. I put my email address on the bottom right. Hope you can see it. I'll be happy to discuss difficult patients, questions, ideas that you have on HAE, and I'm looking forward to our discussion. Thank you very much for your attention. Okay, colleagues, are you ready? I'm sure we have many, many questions here. I'll go to the Slido. If you haven't sent a question yet and you want to ask us something, you can, of course, raise your hand. I'll come to you. Okay, question number one. Let's start from the left to the right. Fulvio, ready? It's from Anonymous. But we don't know. If it's your question and you want to discuss, feel free to stand up. How can diagnostic setups be improved to minimize delays in diagnosing HAE in our region? You know better than me.
Yeah. I mean, that's, yeah, can you hear me, right? So for all of those of you that practice here in the Middle East, you know that there are many organizational and educational barriers that we have to basically crash to reach like this goal. And I guess like, you know, so the question is about like the
diagnostic
setups. You know, diagnostic setups, it's an important thing because while C4 can be easily like, you know, ordered, and we were talking about diagnostics, the other complement studies might be much more difficult to obtain in many centers. There are still centers that cannot order C1 inhibitor level or function.
Really?
Or yes.
How many of you, when you see a patient and you're curious about C1 inhibitor levels, can order protein levels for C1? What do you do? All of you who left here. Do you refer to another center, or what do you do if you want to, oh, this is only for you who didn't have your hands up. What do you do if you want C1 inhibitor? Send away? So you can order. Your hand was up, Amir. I want to know from the people whose hand was not up. How do you do that? You work with a reference center? Yeah?
Yeah, but like just like even for us, it's a send away test.
How many centers in the Emirates can do this?
That's a good question. Like our lab it's a national reference lab and don't do that in the country. So we send it abroad, and you know that like these tests are pretty delicate in terms of like performance. So you get sometimes delay in the results. So it takes maybe 10 days to come back.
Yeah,
and sometimes it's not like, you know, you have like a low activity that
yeah,
you know,
exactly.
You
I
want to
was
check
just
again.
going to say, no, for the levels I could understand, send it away, get the results, you can be pretty certain. But for function, no, in the mail, wherever it is, for many days, you may have impairment. Yes. Look, I mean, I'm the wrong one to say this, but I think we need to do something to increase access to this very important test. In Oman, everyone has this or sends to you. How does that work? Yeah?
In Oman, of course, you know, we start with the history, with the awareness among physicians about the symptoms and signs of hereditary angioedema, and also campaigns, awareness campaigns for patients. They are equally important together with initial diagnostic investigation.
Okay.
And complement 4 or C4 is readily available in all biochemistry labs.
Okay.
But for this C1 esterase inhibitor protein level and function, it's a send out. And we tried to do it before in the past in our lab, but there was some technical problem and supply as well. But it's not a problem. So I think it's not absolutely necessary to have all the investigation in-house.
Yes.
If there are any challenges which cannot become, this test should be sent abroad. But the most important thing is to have that high index of suspicion for this disease among the frontline healthcare workers and also among public.
What do you feel is a good way to increase awareness in frontline physicians, ERs, GPs, family doctors?
I think, conferences and inviting, specialists to speak in emergency conferences, for example.
Okay.
In our grand round, normal activities. We also speak to our colleagues in internal medicine, speak to our colleagues in surgery. Besides this, also, what I found really have high impact, extrapolating from the increased awareness and referral of patients with inborn error of immunity, is to teach this disease to medical students and also medical resident, pediatric residents, to teach them about this disease, because ultimately they are going to be in the front line and they will know about this disease and they will refer these patients early. And this is what we found in patients with immune deficiency, primary immune deficiency. It's taught now to medical students and residents, and we have seen early referrals, early pickup of those patients. So, and it also takes time, but I think awareness is a major, really major step in early diagnosis.
Yeah. This is the biggest diagnostic mean we have. And if we think of it, we can move forward.
Exactly.
If we don't think of it, we lose the trace. No? Okay, any questions from the room? You always have priority. Anything that you want to know from the panel on HAE, how they do things? Plenty of questions on the slide, or you can all see them here. How do you choose between HAE long-term prophylactic options? Iman, I have to ask you first, what options do you have? Do you have all three?
Yes, we do have all three,
Okay.
luckily, in Oman. So really, as you've mentioned, it depends on the patient as well as the treatment options. So we explain the treatment options as well as access.
Mm-hmm.
So for example, the plasma-derived C1 inhibitor is available in two of the centers in Oman, in the capital. One is 3 hours away, but not available in other places.
Okay.
So the treatments really would differ from one patient to another.
Yeah.
And we should take this into consideration, like what you've mentioned in one of your slides.
Yeah.
So bradykinin inhibitors, very easy, available. We provide for all patients for on-demand,
Yeah.
plasma-derived for on-demand as well. However, for the long-term prophylaxis, danazol is widely used in Oman. Yes,
Okay.
it's still widely used in Oman. However, recently now we have started the lanadelumab using, and soon berotralstat for both, and danazol is slowly being withdrawn.
Yeah. Very good. Thanks for sharing. I hope this is similar and of use to all of you. Next question here is, you recommend starting the Berlin protocol from the first dose, from the second. Okay, so the first one is given, patients come in for the second, they get the 14-day injection, and then the next injection we think about, should we go 3-day more? And the main question is, have you had an attack? If the answer is no, we offer to extend and thereby reach the individual treatment option. What about the plan of when to stop the medication? Did any of your patients ask you about the duration of the injectable? Is that, okay. Yeah, very important question. So unlike urticaria and mast cell-mediated angioedema, HAE is a lifelong disease. So the idea of playing for time until the disease goes away by itself doesn't work. There may be, and correct me if I'm wrong, I find that some patients really see this as a moving target. They feel that there are times in their lives when they really don't want to have attacks and cannot have attacks, and therefore prefer long-term prophylaxis. And then they go to times in their lives when they're less concerned about this, or want to see, do I still need that, or has my disease activity changed over time? We generally do not encourage that, because we know it is unpredictable, the disease is unpredictable, and severe attacks can happen at all times. To us, the best solution is stay on the medication, stay on the treatment that works. Why take the risk? No? But patients feel differently about this, and we work with them to do this. So we do tell them that this is something that we will talk about the next time they come in. We see them at least once a year, at least once a year. Even when they have no attacks, complete control, super happy, we want them to come in because we tell them about what's new and how things are going and talk about short-term prophylaxis, and maybe there's a new family member to update the pedigree, all of these things that patients need to talk about.
Yeah, I think, Marcus, you're saying something I agree a lot, which is things might change. So our patient can have different targets in their life. Also, you know, you're much better than me. Like the activity of HAE can modify. You see patients who have period in which they experience a lot of abdominal attack, and then they start having only like peripheral swelling. Like we were discussing yesterday, I had a patient who declined the prophylaxis, preferring opting for an on-demand treatment just for the severe attack. And you can say I would prefer to have like a prophylaxis, but it's a bargain. So you have to discuss with them.
Look, I often see myself in this consultation with patients who say, no, I'm not really sure about this. Let me talk to my wife. And then I hear nothing. And after a year, they sit again, and they're like, oh, so what's your experience now? And they hear, let me think about this, and I hear nothing. No, and the same patient will call me up, can I have an appointment? I really need an appointment. And I'm like, sure, you can come in, and we make an appointment, and the patient will say, I got a new job. I got my dream job, but in this job, I have to travel a lot. So I don't want to jeopardize this career opportunity. Let's do that long-term prophylaxis now. Things have changed in the life of the patient, and that's completely understandable. We will, of course, mirror that, no?
But making them come to the office, that's important, because you can decide to shift to an on-demand treatment instead of a prophylaxis, but it should be a shared decision. They should be trained.
Exactly.
So not stop by themselves.
Exactly.
Which is the dangerous.
Exactly. Hey, how are we doing on time? I could do this all day, but I think, does anyone have the time? Should we be okay? We're already half an hour late. Okay. Mohammed, what do you say? We move to the next one? Okay, then thank you very much for all of your questions. We're all here for the rest of the day, so you can bring your questions to us. I want to thank the expert panels for answering all the questions we got to. Thank you very much. And as we are going off stage,